Good day, class. Welcome to week 2. This is Dr. Bryant. We covered chapters 22 through 25. In our first week, we established the foundation of population health. Now, in Module 2, we shift our focus to healthcare delivery. By the end of this presentation, I hope you'll be able to analyze the history of health policy, evaluate how social determinants of health affect specific vulnerable groups like migrant workers, and identify some clinical gaps in mental health parity. We'll be able to link these policy concepts directly to clinical reality. We start with the history because it shapes our present. For example, the 1985 HECLA report was a wake-up call. As a clinician myself, I see the legacy of this report every day. For example, you notice the shift in language over the decades from reducing disparities to achieving equity. Equity is different from equality. Equity is giving everyone the same pair of shoes. Equity is giving everyone the pair of shoes that fit. In my clinical practice, for example, equity means I spend more time with patients who have complex social barriers, ensuring they can actually achieve the highest level of health. Chapter 22 introduces this social determinants of health framework. Clinically, this is the review of the systems for a patient's health or life. I cannot effectively treat a patient's hypertension if I ignore the economic stability perspective. Are they able to afford medications? I cannot treat obesity, for example, if I ignore the neighborhood environment. Is it safe for them to walk outside? These are not just sociological terms, they are clinical variables that dictate patient outcomes. Look at the data, for example, from your textbook. A 12% drop in uninsured rates for Latino adults is massive. In my clinical practice, post Affordable Care Act, the demographic in the waiting room changed. Patients who previously only came in for emergencies began seeking primary care. However, remember that coverage does not equal access. We still fight provider shortages in rural areas, but the financial barrier has been lowered for millions. Chapter 23 focuses on American Indian and Alaska Native health. The obesity statistics, for example, are alarming, like 31% in youth in this population. But as a population health clinician myself, I know I cannot just lecture a Navajo teenager to eat better if they live in a food desert created by century-old policies. We must understand that health disparities in this population, for example, are rooted in historical trauma and displacement. Effective care requires cultural humility and an understanding of this context. The solution proposed in chapter 23 isn't just about calories, it's about food sovereignty. This is a powerful concept. It means restoring traditional food systems and rights. In the clinic, when I encourage patients to reconnect with traditional non-processed food sources, compliance increases. There is a very significant improvement because it honors their heritage. School plays a pivotal role here. Policy that puts fresh traditional foods in schools is effectively a medical intervention. Chapter 24 uses a striking language to describe the plight of migrant farm workers. It treat I treat the backs and shoulders of the people who pick our vegetables. I see the rashes from pesticide exposure. These patients often delay care due to fear of deportation or losing wages. We must recognize that the fresh food we advocate for in Chapter 23 is often harvested by a population facing severe health inequities, as it was mentioned in Chapter 24. I have worked in mobile health units. They are noble and necessary, bringing care to the fields. But Chapter 24 reminds us that these are downstream solutions. Consider them like band-aids on a gaping wound. To truly impact population health, we must go upstream. We need policy that mandates, for example, water breaks, safety gear, and a decent housing. As nurses, we must advocate for the policy change, not just staff the van. On Chapter 25, we notice this unfulfilled promise being discussed about mental health parity. The law says that coverage must be equal, but the data shows insurers deny mental health claims twice as often. I mentioned this in the guidance to this week or the overview. This is a violation of civil rights. Mental health is at the same as physical health. In my practice, I see the devastation of untreated addiction simply because the paperwork barrier was too high. We must enforce the laws we already have. I close this discussion with a call to action. Remember what Lillian mentioned? She said it best. We must seek out the deep lying basic cause. I personally urge you, don't just assess the patient, assess the policy that puts them there. Whether it's a school lunch programs, farm worker safety, or insurance parity, your advocacy is as critical as your pharmacological knowledge or your assessment knowledge. Let's use our collective voice to shape the health of our populations. All the discussion today was based on Mason et al. 2021, covering chapters 22, 23, 24, and 25. I appreciate your attention and your time listening to this discussion. If you have any questions, don't hesitate to reach out to me. Thank you, Dr. Bryant.